Hi, welcome everybody, and thank you for joining us after what I'm sure is a very busy day in the workplace today. We'll be joining our webinar this evening on lung cancer symptoms and screening. We're very lucky today to have two esteemed speakers. We have Dr. Nitika Silhi from the North Central London Cancer Alliance. She is GP lead for that organisation, and also Professor Neil Navani, who is consultant respiratory physician at UCLH and also clinical director of the lung cancer screening programme at North Central London. And good evening, Michael. Just
Hello.
to introduce myself as well, my name is Marsha. I'm your chair for this evening. I'm a community pharmacist, and I also work as a support pharmacist at the Middlesex Pharmaceutical Group of local pharmaceutical committees, of which one of our committees is Barnet, Enfield and Haringey in North Central London. And we're supporting North Central London Cancer Alliance with this programme. The session, just to let you know a little bit of housekeeping, we are recording the session this evening. We will be now I'd like to introduce Dr. Silhi, GP Cancer Clinical Lead, for her presentation. Thank you.
Thanks, Marsha, and welcome everyone this evening. We're talking about lung cancer, the most common cancer worldwide, and in the UK, the third most common cancer. However, it is the cancer that causes the most cancer deaths, whether that be in NCL, in the UK or abroad. Around 49,000 people are diagnosed with lung cancer each year in the UK, and there's a pretty even split of 52% male and 48% female. In NCL, we have over 1.8 million residents across our 5 boroughs, and with a national incidence rate of around 80 cases per 100,000 people per year, that potentially means nearly 1,500 new diagnoses of lung cancer per year in NCL. In the years 2015 to 2019, incidence rates in Islington and Haringey were actually higher than national rates, which potentially means that there were more diagnoses. Now, if cancer is caught early at stage 1 or stage 2, it's easier to treat, and more than 50% of people will survive for 5 years or more. If, however, it's caught late, then that survival rate drops to less than 5%. Next slide, please. If we look at the risk factors for lung cancer, we can see that smoking accounts for over 70% of new cases. Men in particular have a higher smoking rate, and the smoking has the highest prevalence in the 35 to 44-year-old age group. In NCL, smoking prevalence is 11.4%. However, if we look at individual boroughs, Enfield has the highest smoking prevalence in London at 18.5%, which is the equivalent of 53,000 residents who are putting themselves at risk of lung cancer. Whereas somewhere like Camden only has a prevalence of 6.6%. Despite this, we still have between 10 to 20% of new diagnoses of lung cancer in non-smokers. And while the average age of these diagnoses are similar to that of smoking-related lung cancers, younger patients and female patients are more likely to have never smoked. So what are the other risk factors? Well, air pollution accounts for 8% of new lung cancer diagnoses in the UK, and the risk is higher for those living near major roads, which sadly feature heavily across NCL. We also have a risk factor of obesity. 1 in 2 adults have excess weight in North Central London. Obesity is a well-established risk factor for developing many cancers, although the link to lung cancer is quite nuanced and strongly influenced by smoking. Next slide, please. The respiratory system includes everything from the nose and the mouth down through the trachea, the bronchi, and into the lungs. The 2 main types of primary lung cancer are non-small cell lung cancer, which is the most common type of lung cancer, and then small cell lung cancer. Lung cancer doesn't always cause problematic symptoms in its early stages, and many of the signs and symptoms listed on here could be caused by other medical conditions. So if any of these symptoms worry a patient, they should ideally be checked out by a health professional as soon as possible. Looking at those common symptoms, we have a cough lasting 3 weeks or more. This could be a new cough. It could be a cough that's there most of the time, or it could be a change in the usual cough of a patient. There's repeated chest infections, so chest infections that keep coming back, or chest infections that don't improve with treatment. If they're coughing up blood, or even if they're coughing up phlegm or sputum with blood in it. Breathlessness. That's getting out of breath doing things that they used to do without a problem that is now causing them a problem. Unexplained tiredness or weight loss, and in particular, losing weight without trying to lose weight. If they've got an ache or pain in the chest or shoulder that has lasted for some time, if they've got a hoarse voice or a loss of appetite. Less common symptoms include changes in the shape or swelling of fingers and fingernails called finger clubbing, or pain and swelling in joints, a rare syndrome called hypertrophic pulmonary osteoarthropathy, or Bamberger-Marie syndrome, which is caused by substances released by the tumour and can affect predominantly the wrist and the ankles. Next slide, please. Community pharmacists have a crucial role to play in reassuring or encouraging anyone with any of those symptoms to seek further help from their GP surgery. The clinical role of pharmacy staff has significantly increased in England in recent years, and there are now several pilots testing models where community pharmacists can directly refer people with suspected cancer symptoms to primary or secondary care. Community pharmacy is highly accessible. They have a higher number of patient contacts, even more than primary care, and an estimated 95% of people will visit a pharmacy at least once in a year. Community pharmacy is also conveniently located, with a greater density in the most deprived areas. Most people in NCL will live within a 20-minute walk of a community pharmacy, and sadly, the same cannot be said of GP practices anymore. Early diagnosis of cancer activities in community pharmacy can fit into two broad types of activities. One being just raising awareness of cancer and cancer screening programs to identify high-risk individuals. Or the second option is patients who are presenting at community pharmacies with red flag cancer symptoms, such as the ones that I've just described, and being encouraged by their community pharmacy team to seek further help. Pharmacy staff can identify and engage with people at a point where those people may not have necessarily thought about consulting their GP, and this could lead to earlier diagnoses of lung cancer, which means those people are more likely to be successfully treated. We all know that people delay their presentation for a variety of reasons. In NCL, we know that there's poor awareness about the signs and symptoms of cancer, particularly symptoms that could relate to other health issues, like the persistent cough. A lot of patients just don't realise their symptoms are serious. Some of the more older and more stoic generations worry in particular about wasting their GP's time for something that they feel might be quite minor, like the niggling pain, for example. They may also fear what the doctor might find. In GP training, we talk about a gut feeling and the feeling that something isn't right when we're making an urgent suspected cancer referral. The same rings true with our patients. Many of them will know that something isn't quite right, but they're so worried about the possible consequences, they won't do anything about it. Community pharmacists can help find and reassure these patients whilst encouraging them to attend their GP surgery. They could be someone you've noticed repeatedly buying cough syrup over the past 6 to 8 weeks with no resolution of the cough. In NCL, many of our pharmacies are in the most deprived areas of not only London, but of the UK. Residents there will have higher than average rates of smoking-related ill health, including lung cancer. So there's arguably a greater potential to identify undiagnosed lung cancer or other conditions such as COPD in that local population who are visiting those pharmacies. So conversations reassuring patients and saying that they wouldn't be wasting their time, the GP's time, or that the consultation will be confidential, that happen in a pharmacy are really important. In general practice, we value that conversation, and we would encourage you to pinpoint those patients back to general practice. Next slide, please. So what happens when you send the patients to us? In many practices in NCL, there's now some form of triage, and provided the patient has told the GP what their symptoms are, patients should get triaged to have an assessment with a clinician. Following that assessment, they may try some form of treatment first, such as antibiotics or inhalers, and ask the patient to return if there's been no improvement. If there are worrying symptoms, then the GP may send the patient to have blood tests or a chest X-ray. All chest X-rays in North Central London are now walk-in. The patient just needs to turn up in walking hours, Monday to Friday, to any of our hospital trusts with the request form in order to have their X-ray. Alternatively, there's Wood Green Community Diagnostic Centre or Finchley Memorial CDC, where opening hours are slightly longer and they're also open on weekends. Once investigations have been ordered, the results are sent back to the practice. If the blood tests show changes due to lung cancer, or if the patient is over 40 and coughing up blood, then the GP might make an urgent referral via the urgent suspected cancer pathway to the hospital. If the results are normal and not indicative of lung cancer, the GP might explore other diagnoses to try and explain the symptoms. If the chest X-ray is abnormal, then in most hospitals now in NCL, this will automatically trigger an upgrade and the patient will have a lung CT either on the same day or within 5 to 7 days of the X-ray. The results of this CT will then be actioned accordingly, and if necessary, a direct referral to the hospital will be made. Thank you. Any questions?
Thank you, Dr. Stilley. That was very enlightening. I think that was very clear how important community pharmacy is in this conversation to raise awareness, as you say, and to pick up the red flag symptoms. Patients may not even be aware that they are harbouring red flag symptoms, and a sensitive conversation may enable signposting to a GP for an early diagnosis. Was that so clear? We don't have any questions. There are no questions in the chat.
No.
No? Okay, let's move on then to Professor Neil Navani. Thank you very much.
Thank you very much, Marsha. Hi, everyone. So I'm going to just give you a little bit of a update on screening for lung cancer. And the headline really is that we now have a national screening program for lung cancer. As you've just heard, lung cancer is the biggest cause of cancer death. So this is a real change in the way that we're hoping to tackle the sort of the epidemic that is lung cancer. In fact, it kills more people than the next two most common cancers put together. So in men, that's prostate and colorectal, and in women, colorectal and breast. So it really is a sort of a major health problem. So having a national screening program is a major change to how we look after lung cancer. So that screening program currently is for people aged 55 to 74, and they have to be current or former smokers. And we've actually been screening in North Central London now for a number of years. And the fantastic news is we've managed to screen, we think, 100% of the eligible population who have at least been invited for lung cancer screening. So this is a real achievement, and I think we're the first cancer alliance within the country to have been able to invite all of the eligible people within our area. It's across the actual scanning. The screening processes I'll take you through in just a minute, but the sites where participants are met include UCH, but there's also Finchley Memorial and also the Wood Green Diagnostic Centre as well. So one of the key problems with lung cancer is that people used to present, and people still commonly do present, with advanced disease. So by the time lung cancer causes symptoms, it usually implies that it's spread. And once lung cancer has spread, so it's spread to bone, liver, or brain, for example, then it's very difficult to treat effectively, and certainly not possible usually to cure that cancer. So what lung cancer screening does is detect cancer at a much earlier stage, often when the lung cancer has no symptoms or signs. So you've just heard about some of the red flag symptoms. Actually, the majority of patients I see with lung cancer now in my clinic have no symptoms whatsoever. And this is because they've come through the screening program, which detects early stage lung cancer, which doesn't have symptoms, but can be cured. And the amazing thing about the screening program within our area is that 80% of our lung cancers now are being seen at an early stage, so stage 1 or 2, where the cancer has not spread outside of the lung, and therefore those patients can often have surgery to cure their cancer. Can I check that you can see the slides moving forward? Is that okay? Yeah. So this is the screening pathway, and you can see that we invite people aged 55 to 74, and this is usually extracted from GP IT systems and people who are coded as ever smokers. And then invitation letters are then sent out by the screening team, which are based at UCLH. So the patient receives a letter, and at the same time, the letter also contains an appointment for a telephone call. And that telephone call is with a member of the lung cancer screening team, and they do a couple of things. So they try and determine their risk for developing lung cancer, and also give some very brief advice for smoking cessation and make an onward referral for smoking cessation as well. So during this telephone conversation, it can also happen face-to-face if required, but during this telephone conversation, if it's agreed that the participant is eligible for screening, so that means that they meet criteria, then they will be invited up for a face-to-face lung health check appointment and a CT scan. So the screening is done with a low-dose CT scan. If they are not eligible, then they are re-invited again in 2 years to recheck if they only just missed the cutoff. So once the patient who's eligible has had a CT scan, again, the smoking cessation advice and referral is really important and emphasized again when they come for their CT. So this generates a scan, and usually within 28 days of the scan, results are available and the patient and the GP are informed of the outcome of the screening. If the scan is normal, that's obviously very reassuring, and the person is invited back in 2 years' time, providing they're still within the age range. If, however, there's an abnormality found on the CT scan, the screening team will pick that up and refer into their local hospital for further management, and that can be a referral to the Royal Free, the North Mid, Whittington, or obviously UCH as well. So that's the general pathway. So over the last 3 years or so, this has been a massive effort led by the Cancer Alliance and delivered by the screening program within UCLH. And so far, over 140,000 eligible people have been invited, and pretty good uptake. Overall, 77,600 have taken up the opportunity to have that telephone call with somebody from the screening team. So that uptake varies a little bit across our patch. So the highest being in Barnet, which is 58%, and the lowest being in Camden. The government are very keen that we have a target of about 58% overall. So this is something that we're hopefully close to meeting. A couple of other things about uptake is that it's higher in the least deprived areas compared to the most deprived. That's often something that we see in screening programs, and is also higher amongst females, and also the slightly higher age group as well, the 65 to 74-year-olds. But overall, this is generally seen as a good success story, and it shows that lung cancer screening can be delivered at a population level. So if something is found on the lung cancer screening scan, then often the patients are referred in to see a specialist within the hospital. And this will, if it's obviously a suspected lung cancer, this is going to be to the respiratory physician. And then there's a large number of tests that the respiratory physicians within secondary care carry out to diagnose and stage lung cancer. It always starts with a CT scan with contrast, and then most patients go on to have a PET scan. So these scans tell us the extent of the cancer, if there is one. And then it's quite important for us to do also a biopsy. And this can be done via a variety of methods, including a needle biopsy through the skin, or via a telescope down the mouth into the lungs, which is a bronchoscopy, of which endobronchial ultrasound is a type of bronchoscopy. The thing that's really changed lung cancer diagnostics in the last year or two is robotic bronchoscopy, and we now have that within UCLH, and many of our patients diagnosed via lung cancer screening undergo a robotic bronchoscopy. So a large number of diagnostics available, and then equally there's a large number of treatments available. And the treatment of lung cancer is fairly complex, but there's one overriding principle, which is that it depends upon the stage, which essentially means how the cancer has spread and where it has spread. So if it's just within the lung, then surgery often offers the best treatment. If it's spread to some lymph nodes, then radiotherapy can be really effective. And then often now we combine these treatments with immunotherapy or targeted therapies. And it will be common for patients to have radiotherapy together with chemotherapy and then followed by immunotherapy, for example. So there's a variety of options that patients very commonly undergo. Immunotherapy has really become a backbone of treatment, though, for most of our patients with advanced lung cancer. Those who, as was mentioned earlier, who perhaps have never smoked, may have genetic drivers to their cancer, and in those patients, targeted treatments like osimertinib and others can be really effective for lung cancer, particularly in people who have never smoked. So what can how can pharmacies help? Well, there's a variety of ways I think you've already heard about. In addition, perhaps, a key role might be to support patients to live well with cancer. Many patients with lung cancer are on oral anti-cancer medicines like osimertinib. And obviously community pharmacies are well placed to help these people. What I would say is that if you meet people of the age of 55 to 74 with a significant smoking history, or perhaps have smoked in the past, then it would be important to signpost them to the fact that there is a national screening program for lung cancer, and that they should be able to take part in that if appropriate. Obviously, it would be really helpful to also educate on signs and symptoms of lung cancer. As you've already heard, it can be sometimes difficult to distinguish between symptoms of infection, but also sometimes helping with medicines they're already on. So many patients with lung cancer have coexistent respiratory conditions. Obviously, COPD is an important one, and many patients are on inhalers, and it's really important to maximize and get the most out of those medications so that they can benefit from lung cancer treatments. And many people also want advice on storing of anti-cancer medications, as well as understanding some of the side effects. Obviously, many patients with advanced lung cancer do experience pain, and community pharmacies are a really important additional way of managing symptoms such as pain. I've already mentioned that smoking cessation is sort of integrated very closely into lung cancer screening. But obviously, even if people are not eligible for lung cancer screening, they should still be given smoking cessation advice if they are current smokers. And perhaps sharing lung cancer symptom awareness would also be really important. So I think these are things that community pharmacy have traditionally been really strong at, and hopefully will continue to deliver. Obviously, it's always fantastic. I think people are always reassured when they see signs in their local pharmacy supporting public awareness campaigns. I think they really take notice of that. So it's really great to be able to display flyers and posters about lung cancer, and starting to break down some of those barriers and taboos about lung cancer that do exist, and some of the nihilism around it. It's a curable cancer. Our survival rates in North Central London are the highest in England. They're amongst some of the highest in Europe and worldwide. So because of our screening program. So we don't want to lose the benefit of that. We should be publicising that a lot more. And hopefully community pharmacies can also be part of that. And perhaps be a source of booklets, or someone also to provide in-person appointments as well. But particularly, I think this issue about opportunistic conversations, I think, is so important. We've talked about the uptake being at around the 50% mark. We want that higher in NCL. And perhaps some of those people who walk into a community pharmacy might be exactly those who would benefit from lung cancer screening and help to increase their uptake. And, that reminder about that letter they received might just nudge them to take up that lung cancer screening appointment, which would be really useful. There's lots of resources for people who have other questions about either the screening program or lung cancer more generally, particularly the CRUK website and the Roy Castle Lung Cancer Foundation websites are really excellent in terms of providing further information about lung cancer.